Welcome again to Edu-PIC. This is Ahmed Sharif talking to you again about renal replacement therapy in PICU. Today we're going to talk about peritoneal dialysis. As we've talked before about dialysis, there are multiple modalities in the pediatric settings, but in PICU we're mostly focusing on peritoneal dialysis and continuous renal replacement therapy. For the sake of being more specific today, we're going to talk about peritoneal dialysis as a start. We're going to try to cover the principles and theory behind peritoneal dialysis, as well as covering the application and managing of the process. Let's start with principles. So peritoneal dialysis was first introduced in the 1960s, but since it is still the most commonly used renal replacement therapy modality in children under 6 years of age, it still is the standard method in any post-congenital heart surgery, and it's quite common to find a child coming back from theaters with a surgical PD catheter inserted. It is low cost, so it's actually very useful in developing countries, and it's also safe and doesn't need extensive training, which also makes it the modality of choice for developing countries. Hence why we're discussing it in some details today. Well, how does it work? Well, using the peritoneal membrane as our filtering membrane, we get some fluid instilled into the peritoneal cavity, and using the principles we've talked about last time, depending on the concentration of specific particles in the fluid, we can manage to get some of the higher loads of these particles and toxins from the bloodstream, from the plasma, into our fluid. And also, with the fluid shifting from within the plasma, we can get some of the blood solutes dragged with it, which is achieved via convection. Eventually, depending on the fluid osmolality that we're using and the time that we keep the fluid in, we can shift more fluid from the body out with the dialysis fluid all through the catheter. So we can achieve solute removal and we can achieve fluid removal via ultrafiltration as well. Okay, we're not going to talk a lot about principles. You can always read about that. But let's talk about pragmatic issues like inserting a PD catheter and get going with starting the dialysis. First thing that you need to know is there are multiple types of PD catheters that have been developed over history. These catheters can be anyway from rigid catheters to pigtails to just flexible cylinder catheters. Usually they come in kits. The kits will include the catheter, introducers, needles, syringes, and if you're using a cylinder technique, then you're going to be using wires. You can see that here as well. So this is more detailed with a catheter, an introducer, dilators, a sheath to help introducing the catheter as a cylinder technique, and a wire. Again, if the patient is coming from theaters, expected to need a catheter as a possibility, then it's always useful to have a surgical catheter inserted intra-op. Okay, so you've got your kit, you've got your syringes, you've got your flushes. What else do you need? Well, you need your nursing team to prepare what you're going to connect to the catheter. So as soon as you get the catheter in, you need to be able to connect it to the circuit where there's the solution bag that you're going to put in the peritoneal cavity and the draining bag for drainage afterwards, which means you need two infusion sets to be connected together either via, drip regulators or via three-way taps or whatever you can use to control which way the fluid is going. Because if you put it like that, then you can imagine like this is your solution bag, it's hanged up. The fluid is going to go down by gravity. Do you think it's going to go in there, or do you think it's going to go falling down to the draining bag right away? So definitely not the way. But what you need is somewhere in there where you've got something like a three-way tap or this design with 3 drip controllers where you can control how things are going and where they're going so that you can manage to get your fluid in at one go, and then you manage to get your fluid out on the other go. And you can sometimes also organize how quickly it's going. All right. Then to insert a PD catheter, we need to get to know some of our surface anatomy, like where are we getting to put that catheter in an acute setting. Obviously, if you look into textbooks or look into guidelines, the guidelines when you're putting a PD catheter for a renal ward is a bit different than what we're doing in acute settings. What you need to know in acute settings, to be pragmatic, is you've got mainly 3 entry points. Either you go midline in the mid rectus abdominis, so where there's no muscle, just a sheath. So and you go below the umbilicus, and you try to avoid any vascular injuries. You also can go midpoint between the umbilicus and the anterior superior iliac spine on either way. We prefer usually the left side so that you're far away from the liver, just in case there's a liver enlargement, whatever. And you again try to be lateral to the muscle wall and away from the epigastric arteries and vessels. These areas can be safe areas for you to go in with your needle. But you also need to remember that you've got many tools that would help you to avoid injuries. So the ultrasound can be one of these tools. So if you put your probe initially, so you get your surface anatomy, then you put the probe, you make sure that there are no vessels that you're going to hit using the color, and try to identify where the muscles are so that you can avoid hitting within the muscle. Then you can actually look for a good entry point, and it's usually going to be around where the surface anatomy is. Also, ultrasound is useful for you to find pockets where you can go with the needle not hitting any intra-abdominal contents. So if there's any intra-abdominal organ enlargement, or like there's a bit of the gut that is adherent to the peritoneal wall, you can possibly identify points where you can go in with the needle and not hit any of that. And when you manage to identify your surface anatomy point that goes with ultrasound findings that would tell you that this is the safe point for you to go, get ready for a sterile procedure. You need to remember that you're putting a drain or a catheter in the peritoneum, and if it's not sterile, then you can cause peritonitis, which is a very serious complication if it's not sterile. So, still getting ready to insert your PD catheter. What else do you need to think about? So we've talked about your kit, you've talked about the nursing bit where they're preparing the circuit. We talked about surface anatomy and knowing where you're putting your needle. We talked about the fact that you need to keep things sterile, so get ready with your sterile gloves, with your Chlorodex and everything else. What else? Well, you also need to think about pain management and sedation, because you can't put a PD catheter safely in a child that is kicking and panicking and not really managing to stay still. So, but you need to remember that if the child is not intubated and ventilated, that can be tricky. Possibly for procedural input, ketamine is a very good choice. Along with ketamine, you need to remember that ketamine is not going to be your only answer. You might need some morphine or possibly opioid input, and it might make your job easier if you use a local anesthetic. But if you're going to do that without intubating and ventilating the child, then you'll need more hands on deck. You need to always prioritize safety of the procedure. So the safety should be all directed to your patient. You need to think, is it safer for me to do it? Do I have many hands on deck with skilled airway management, with someone who can sedate and manage the airway without having to tube the child? Or is it just safer for me to tube the child? You need to remember that if you haven't done that more often, then you might need senior supervision or attendance just for the procedure itself. In that case, that senior supervision can't be used to manage the airway if the child is not tubed. You also need not to jump in doing a PD catheter if you haven't seen one before. Our advice is to see one, do one while closely supervised, then do one independently, then teach one. Having said all of that, I think our advice as Edu-PIC would be for the procedure to be usually done in an intubated child. Well, how do you insert a PD catheter? as I said before, you can still use the ultrasound to your advantage, where you can see in real time where you're going with your needle and if you're hitting any structures or going into the pocket that you've identified before. Don't forget that this still also needs to be sterile, so that ultrasound probe needs to be either covered with a sterile cover or a sterile glove even, and to facilitate the procedure. Try to get your needle to be going in a 30-degree angle so that you can control how it's going without being steep, so that you can minimize any injuries. And that would also facilitate the fact that you can see your needle using the ultrasound. So as you can see, when the needle goes with an angle, no matter how deep you go, you still haven't really hit any of the structures. Also, it would be really useful if you, after you put the needle in, try to draw and see if you're getting blood, or you're getting serous fluid, or are you getting some of the intra-intestinal fluid. That would let you be more aware of what you're doing. If you're feeling safe and you're getting just serous fluid or nothing at all, it would be advisable from some points of view to prime with fluid. So if you push about 10 to 20 milliliters of saline down your needle, then you're possibly making it easier for you to insert your catheter without hitting any of the intra-abdominal organs whatsoever. So as soon as you get to that point, you can continue with your Seldinger technique. So you prime with your wire through the needle, and as soon as the wire is flowing all the way in with no resistance, with no problem, then you draw the needle, and then you get your dilators in, you get the dilator out again, and you get your catheter in. That is usually the case with most of the non-rigid catheters. Most of the rigid catheters would be difficult to insert using Seldinger technique, and that's not the case that we're talking about in this presentation, as the rigid catheters will need possibly scalpels and more surgical techniques to help putting them in. Right? As soon as you've put your catheter in, you need to remember to connect it right away to this closed circuit that your nursing team has prepped for you. And then you can start your PD process. Okay, so you've put the PD catheter in. Now you need to know what are you doing with your solution and what is your dialysis plan and how do you control it. Okay, let's start with the simple stuff. Just remember your peritoneal dialysate should be warmed to body temperature before starting dialysis, except if you're deliberately trying to cool the patient down. Your PD catheter should always be connected to a closed system, even if you're not in active dialysis, or even if you're thinking you're not going to be using it for the next 24 hours. It should be clamped and closed into a closed system. There is good advice and evidence that you should give prophylactic antibiotics within 60 minutes prior to your insertion of the PD catheter to protect from possible peritonitis. And then, according to the International Society for PD and the guidelines that they've come up with in 2020, your dialysis solution should include dextrose in a concentration desired to achieve ultrafiltration. Don't add potassium to your fluid unless your serum potassium has fallen below 4 millimoles per liter, or if you're starting your dialysis while your potassium is at that level. For the first 24 hours, you need to do USENIs or electrolyte levels every 12 hours, and then 24 hourly for the next of your days, except if you've changed your regime, then you go back to 12 hourly. Always remember to document, and you also need to remember that your initial fill volume should be limited to 10 to 20 ml per kilogram to minimize the risk of leakage, and that your initial exchange duration, including inflow, dwell, and drain times, should be around 60 to 90 minutes as a full cycle, while in neonates you might need to go for shorter periods. To emphasize more, what is fill time? Fill time is the time that you spend with your fluid going into the interperitoneal cavity from the dialysate bag. That should usually be less than 10 minutes. Your fill volume can be increased gradually as tolerated. As we said, it starts at around 10 to 20 milliliters per kilogram, but you can keep increasing that gradually as tolerated to achieve dialysis targets. while the dwell time, which is the time that the fluid spends intraperitoneally before you start getting it out, should usually start at more than 20 minutes, and then you start adjusting it according to the targets. The high osmolarity of the fluid will shift more fluid with it through ultrafiltration, as we've talked about these principles before. The hyperosmolarity means more dextrose, which means possibilities of hyperglycemia, as some of that dextrose shifting into the plasma. Your initial PD cycle that we would suggest as an example will have a fill volume of 20 milliliter per kilogram, fill time of about 5 minutes, dwell times of about 45 minutes, and then get it out in around 10 minutes. Your PD solution for acute PD dialysis is usually available in concentrations of 1.5%, 2.5%, and 4.25%. You can sometimes make your own fluid if you don't have these commercially in your country or in your setting, but that will need to be done in complete sterile environment. If the patient becomes hypocalcemic, you don't top up the calcium within the fluid because it can be sedimented with bicarb, and most of these fluids have some bicarb in them, so you top up your calcium either IV or enterally. If the patient has got hepatic dysfunction or has got persistent or worsening metabolic acidosis despite dialysis, you can use the bicarbonate containing solutions, or if you don't have them, you can use some of the lactate containing solutions as alternative. Again, as you're designing your own fluids in some of the countries or where you don't have these commercially, you can still use some of the guidance that you can find in some websites like the ISPD, which is the International Search for PD guidance. Locally prepared fluid, as we said, may be used, but you need to know and be sure that you're doing that in a sterile environment. It is a common practice to add 500 international units per liter of heparin to the dialysis to prevent fibrin clots. And you still need to add antibiotics, usually gentamicin, to the peritoneal fluid itself to cover against peritonitis. Let's talk about some situations and how to tackle them. So if you're targeting urea as one of your main targets in your dialysis process, then 1 hour dwell time is usually sufficient to get enough urea on acceptable rate. Remember that if you shift a lot of urea really quickly, then you might get the patient into cerebral edema. Then you can adjust your dwell times according to your urea clearance accordingly. The potassium, on the other hand, will be shifted in shorter dwell times. So if you're not using longer dwell times, you're going to possibly be shifting lots of potassium really quickly in most standard fluids where you haven't added potassium. So be careful, because half-hourly rapid cycling can be enough to get that much of potassium. Another molecule that you don't want to shift quickly is sodium. So if you've got high plasma sodium, you need to lower that slowly. And if the patient is very hypernatremic, and that's why you're doing the dialysis, then you might need to add hypertonic sodium chloride into the dialysate itself to get the levels going down slowly rather than quickly. If you're targeting fluid overload and you want to shift more fluid really quickly, then get the osmolarity of the dialysate to be on a higher level. So rather than 1.5, maybe start with 2.5. And then if that's not working, you can go up with 4.25. Get the dwell time to be shorter, because most of the fluid removal happens in the first 20 to 30 minutes of the dwell time. And you can increase the fill volumes cautiously if you need to shift more fluid accordingly. But you need to remember that that's going to affect also some of the solutes like potassium and calcium. Then, if you're having problems with leakage, then you need to address that. So first of all, to avoid leakage, don't start with big fill-in volumes. Also, the catheter should be well anchored and well supported. You can, if you find leakage, you can start by applying some pressure dressing to get some pressure around the catheter so that the leakage goes down. You need to know the weight of that dressing before putting it there. So if it's wet, you can weigh it and know how much is in it. It is useful to try to suture around the catheter to get things to be a bit tighter and see how it is. But if you're still having trouble, then consider changing the whole catheter all at once. So, really important bits to never forget. Never forget documentation, which means documenting the procedure, documenting how much fluid goes in, how much fluid comes out, what's the balance, document your urea and electrolytes levels that you do either 12 hourly in the first 24 hours or 24 hourly. Again, as we said, you can do it 12, you should do it 12 hourly every time you change the PD plan. Okay, and monitor also for the leak. You need to also monitor if the fill-in volume is too big, which is affecting your ventilation pressures, because in that case you'll have to go down with the amount that you're putting intra-abdominally. You need to remember to keep everything being done in sterile environment. You need to keep the catheter connected to a closed system and achieve your dialysis with the lowest fill volumes that you can get in there to achieve your targets. If you need any references to some of what we said or more information about how to constitute your fluids locally or address some of the other problems that we haven't mentioned here, these are two good sources and references to where we got some of our talks and guidelines. Thank you. Don't forget to leave some of your feedback in the comment section and also all of your questions. We are always happy to respond to your questions and happy to hear from you. Thank you very much.